Well, welcome everyone. We have a great honor of having Dr. Williams join us today. Dr. Williams is a board certified plastic and reconstructive surgeon practicing in the San Francisco Bay Area at the Tri-Valley Plastic Surgery. He earned his undergraduate degree from Dartmouth College and his medical degree from Yale University School of Medicine, where he also completed his 6-year internal internship and residency in plastic and reconstructive surgery. Dr. Williams specializes in cosmetic surgery of the face, body, and breast, with a particular emphasis on breast augmentation and body contouring. In addition to his clinical practice, Dr. Williams has held leadership roles at state, local, and national levels, notably serving as the first African American president of the American Society of Plastic Surgeons. During his tenure, he was instrumental in promoting diversity, equity, and inclusion within the organization, aiming to broaden the reach and ensure the need of both physicians and patients from diverse backgrounds. Dr. Williams is passionate for patient care and surgical excellence, and has solidified his reputation in a leading figure in plastic and reconstructive surgery. And thank you again for joining us on a Saturday morning.
Yeah, no, it's great to be here, and I always think that it's really the opposite. It's an honor for me to be here to speak to people who are interested in medicine, who are interested in affecting patient lives, and so this is fantastic. Thank you. So I really want to have this be a little bit informal. I actually hadn't originally prepared a PowerPoint, but I do have one that kind of talks a little bit about my journey. And so maybe we'll kind of start there and just keep it really open, and people can kind of ask questions as they go, because I think that's probably really the most important thing. I know that uh, generally people who are participating in this webinar want to know, how do I get into medicine? How could I be competitive in spaces like plastic surgery or dermatology or orthopedic surgery? And I do think that times have changed a little bit, and there's some things that we can kind of go over, and some strategies to think about. So hopefully that's what everybody's here for, and hopefully kind of my old man gray hair slides are going to be something that are okay, but we can go through them pretty quickly. And if people decide that they want to just jump off track and talk about other things, just let us know in the comments, and we'll do that. So with that said, I'm going to see if I can successfully share my slides here. All right. How does that look? Does that look okay?
Can you try to? Here you go. Perfect.
Great. Okay.
Try to get the previous one. Yep, perfect. Oh, went back again.
Hmm.
There you go. Perfect. Oops.
Okay. That's
Oh,
good.
no, it went back again to the.
I see. Okay. Give me one second here. Well, let's just, while I'm getting it a little bit more set up, what I'm going to do is let me just kind of discuss medicine in general in the United States. And so, those of you that want to be doctors that are considering entering medicine, the whole process of healthcare, maybe I'll just talk. Maybe that's just a little bit of the easier thing. Healthcare itself has kind of undergone a journey, just like everything else. And really, the process of becoming a doctor was very informal in the early days. It was really this kind of preceptorship, mentorship. You would kind of sign up with someone for a relatively short period of time, and they would say, you know what, you're a doctor now, congratulations. And so that would be very interesting if that were still the case. But really, what changed and what happened was something called the Hopkins model. And so the Hopkins model was this concept, and it really came about kind of right after kind of science and medicine began to be more of a prominent thing in the late 19th century. Germ theory, science is really, people were realizing, oh, there's actually science behind how to care for people. And so in the very late 1800s, early 1900s, the Johns Hopkins model came out. And what it was is essentially acknowledging that you had to have an undergraduate degree And then you needed additional training after that to become a physician. And it was largely science-based. And so it was called the Johns Hopkins model. And then the next real transition point was in the early 1900s, something called the Flexner Report, which came out and said that medical schools were completely unstandardized and nobody really knew how to teach doctors. And so then there became this formalized, systematic way to create doctors and how to educate doctors. And so core curriculums and the important steps of making a doctor. So that was kind of what generated out from that. And then in the 20th century, it was accreditation body, more standardization, and then people really began to think about how to teach people, and that was an era where people started to think about diversity and patient populations deserve diverse perspectives in terms of how they care for people, and that's kind of where we are now. And so, before I get too into it, let me just tell you a little bit about me because it's really super important that you know who you're listening to before you give people any credence or take anything from what they're saying. And so, as was mentioned, I'm a board certified plastic surgeon. I practice in Northern California. I originally was doing largely reconstructive work, and so I did a lot of microsurgery. I did breast reconstruction, cancer reconstruction, and a fair amount of hand surgery. And plastic surgeons are trained microsurgeons, we're trained hand surgeons. And so when people think about plastic surgery, they're always like, oh, boobs and tummies and those types of things. But it's really a lot more than that. And so as I progressed, I went to Dartmouth undergrad. I went to Yale for medical school, but it wasn't really a very linear journey. And I think that's something that's really important for us to recognize. When I started, I didn't really know I wanted to be a doctor. I thought maybe I was going to be a lawyer, or maybe I was going to be involved in the space program. And so I think it's really, really important to keep your perspectives open, and the things that you assume, you should be willing to change and to be flexible with that. And so one of the stories I like to tell was a story about medical school. And so I think that medical school is an incredibly special place to learn. And so the things that you guys are trying to achieve and the areas that you're trying to get into, you're right to want to do it. And the story I always like to tell is about the brain room. And so at Yale, when we were in medical school, again, a bunch of 20-year-olds just out of undergrad, kind of a little bit of a wild side. There was uh, there was a very famous neurosurgeon, again from the early mid 1900s, who kept brains and specimens of brains, and he really developed the concept of neurosurgery. His name was Harvey Cushing, and he at Yale, he was a professor at Yale, and essentially Yale started messing up some of his slides, and he said, "I'm going to take care of it." And so he amassed this collection, but they kept the collection in the dormitory underneath the medical school. And right around the time I was a medical student there, we discovered kind of how to get in, and we found this thing. And it was just this really special time where once or twice a year we would kind of sneak in and we would kind of break into this sub basement, underneath the dormitory. And we would just look at all these slides and things like that. And there was this, we made this plaque that we kind of signed. And, the rules were you could never touch anything. You were just really there to observe. But the reason I bring this story up is medical students and the things that you should look for are part of the foundation of what makes doctors special is their intellectual curiosity. And it doesn't always mean that we follow the rules. I'm sure that Yale really didn't want us breaking into this site, and they finally just said this is too much. And I think about 20 years ago, like moved all of it and put it in the library and made this formal exhibit about it. But the point of the story is that you know you want to be curious, you want to explore, you want to not necessarily break the rules all the time, but that kind of intellectual curiosity that maybe transcends some of the social norms are important. And so um, as you're moving forward, one of the things that's really important is to maintain your curiosity, maintain your sense of wonder about science and the human body, and how to make things better, and and really connect with others in order to make the journey of becoming a doctor, getting into medicine, or really whatever your journey is, make that be more attainable because of the networks you build. So I'm going to actually just jump off the stories for a second and just answer a couple of the questions that are kind of hanging out here so we stay on track. Again, I want this to be really, really interactive. And so one of the questions is DO versus PA versus, kind of the more traditional MD practice. And I think that the economics of medicine are very interesting right now. And so I think that generally healthcare is becoming consolidated. And I think that healthcare is probably less and less interesting for physicians. I think there's less and less independence. I think there are financial constraints on becoming a doctor or a healthcare provider that maybe there weren't 10 or 20 years ago. And so I think this question is actually really, really important right now. And I think if I'm looking at my teenage children, I kind of tell them maybe don't be a doctor for a couple of reasons. I think that the career is there's still an enormous amount of debt that people accumulate going into medicine. I think that the pathways are very long. My pathway, 4 years of undergrad, I started a company essentially between undergrad and medical school. And so there was an extra year there, and then 4 years of medical school, and then plastic surgery residency was a 6 year track. And so that's a lot of years. You're essentially giving up your 20s. And even though residency is better tolerated now, meaning that it's kind of less painful and less, those 100, when I was a resident, 120 hour work weeks were the norm. And so I think that's better now, but you're still essentially giving up your 20s if you're going into a highly specialized medical field. And so you have to assess what the value of that is. I also think that as medicine consolidates, there's less and less input that doctors have regarding patient care. And so things like AI, artificial intelligence, really kind of dictating things like these algorithms that large healthcare providers like Kaiser or Sutter, um, they really say, here's the workflow that you take a patient through, and here are the things that you do. And it's really very prescripted about the care that you're supposed to provide to patients. Now, in the surgical fields, there's still a little bit more autonomy, a little bit more freedom. There's definitely a little bit more economic advantage, but all of those things are kind of collapsing and compressing a little bit. And so when I think about sometimes the shorter pathways that physician associates have or nurse practitioners have, and they're still kind of doing some of the same levels of care, especially if you're thinking about pediatrics or internal medicine, those pathways might make more sense, especially from an economic standpoint. And so I think that those are really good choices. For me, when I was training, it was a little bit more about, again, as a black male, uh, there was a lot of you can't do this and you're not good enough to do this. And so for me, it was about ego in some ways. And that's kind of a horrible, weird thing to say. But, I had this internal voice that said, I just want to be the best. And I just want to do something that's highly, highly competitive. And I still think that that MD track is still probably the most competitive. And certainly things like dermatology, orthopedics, plastic surgery are the most competitive specialties. And so part of it was about justification. And we all talk about imposter syndrome. And I can definitely spend some time talking about that, but I think it was kind of that fighting to show that I was, as good as anybody else around me. And that was also part of how I chose the schools I went to. My parents were very much, I got into University of Arizona, I had a full ride. And I didn't have a full ride because I was a particularly brilliant student in high school. I was an okay student. I mean, I was a good student, but I wasn't like straight A's, all the rest of those things. I was a particularly good test taker, so my standardized test scores were great. But my father was a physician, and my father worked at University of Arizona, and so because of that, I had a free ride. And my parents, and so I got into Dartmouth College out of high school, and I told my parents, well, that's the only Ivy League school I got into. That's where I'm going. My parents said, well, we're not going to pay for it because you have a full ride at University of Arizona, and that's where you should go. And I said, that's terrible. And I actually really couldn't assemble the financial pieces in time to really go. And so I went to University of Arizona for a year, and I was mad and kind of despondent and really concerned, but I applied as a transfer student. And what was really scary is some of the other schools I got into right out of high school initially rejected me as a transfer student. And I was like, oh my gosh, I'm stuck at U of A, which was probably would have been fine in all honesty. But Dartmouth, I got into as a transfer student, still couldn't afford to go, started a company that did some technology things, did some publishing things. And that was what actually built up enough funds for me to go. So I took a year between my freshman year at University of Arizona, started my company, and then went to Dartmouth as a transfer student. And I just tell that story because it's important to realize that you're going to run into these obstacles. You're going to run into things that hold you back or you see as insurmountable. But just stay true to yourself. There's always another way. There's always another step. It may take more time. It may take more effort, but there's always ways in. And so that brings up a lot of other topics. I can talk about imposter syndrome. I can talk about, getting into these schools. I can talk about, starting. The nice thing about I think the current era is there is a lot of kind of that hustle culture. I think that innovation, technology, those things actually are much more accessible um, to younger people in terms of building things in companies. And so we can talk about all that too if people want to. But I'm just going to kind of keep going through the questions. That's probably the best way to handle this, unless you guys want me to jump into boring slides again. And so reflecting on my career, sacrifices were all worth it. Yeah, I mean, I don't know. I mean, I'm very happy with where I am. Again, for me, part of it was answering kind of this internal inferiority complex I had. Part of it was just saying, I want to be able to look someone in the eye and say, I have just as good an education as anybody else in the world. I have done things that, only the best people could have done. And so um, I think that passion is really powerful, and it's been a source of, I think, some relatively good accomplishments in my life. So, I multiple Ivy League educations, a very successful practice, the first African American president of the American Society of Plastic Surgeons, which is an international organization, and it's had a history of 100 years of time. But in some ways, and this answers another question about work-life balance that's also just below this, in some ways, I'm never happy. And I'm okay never being happy. And this is a little bit, for those of us on the West Coast, maybe that's a little bit more of an ethic that resonates with people. I have a hard time finding satisfaction. I have a hard time saying, oh, good job, that's great. Now, we're satisfied. It's always like, okay, what's the next thing? Um, what's the next barrier to breakthrough? What's the next thing that they say can't be done? And I think that's nice in terms of being that driving force for accomplishment. It's probably relatively challenging on my wife and on my family and around among my employees, right? Because at my practice, I'm like, okay, here's the next cool thing we're going to do, and that passion kind of drags the people around you um, for the ride. Now, I have an incredibly accomplished spouse who also multiple Ivy League, degrees and has all these other accolades, is not a physician. But you have to be able to work that passion into your life. Work-life balance doesn't make as much sense to me because I'm an old man. And when I was a resident, there was no such thing. And I'll tell a little story about that. And so I got engaged as a PGY 5, which means postgraduate year 5. I was a plastic surgery resident, and in the old days, when you were a fifth year resident, you were essentially an attending. And what that meant was, I could come into the hospital and just start cases by myself, even when the attendings weren't in the building. And so that was never be allowed nowadays. And there's a lot of responsibility. If someone died or you hurt someone, you probably would get fired from your program, but there's a ton of pressure just to be great. And uh, there was never an excuse. The adage was you were in the hospital one way or the other. Either you were rounding or they were rounding on you. And it was kind of a joke, but it was kind of really true. And so I remember I was operating with this famous plastic surgeon, a guy by the name of Steve Arian. He's kind of the father of melanoma care, and he's invented all these different plastic surgery techniques. And and he's still practicing. He's still kind of, he's slowing down now, but he's still publishing research. He's still incredibly well respected at Yale. And he had just stepped down as chairman, and I was operating with him. And again, PGY 5, you're pretty much, you're not really, they know you and they know that you're going to make it, and they trust you. And we were operating, and I'm like, oh, Dr. Arian, I've got news. I'm going to get engaged. I'm getting married this year. And he said, if I were still chair, I wouldn't let you get married. And like I felt like the entire operating room just stopped. It felt like the beeping of the anesthesia machine stopped. It felt like the nurses just froze in place. And there was like this moment of silence. And he took that pause and he said, look, your mission, your only job right now is to become an amazing plastic surgeon. Everything else is secondary. You shouldn't be worrying about other people in your life. You shouldn't be focusing on family or keeping your wife happy or having a happy marriage. You need to be only becoming a plastic surgeon right now. And again, it felt like that silence lasted forever. And then I kind of thought about it for a minute and I realized I think this guy likes me. I think I'm okay. And I kind of laughed. I'm like, well, it's good that you're not chairman anymore. And then like paused and then he laughed and it was all fine. But that statement, he really meant it. And he was very, very serious about it. And I tell that story to tell one more. The longest case I ever did was in residency. It was this with this plastic surgeon. Again, PGY5. I was a fifth year. There's a gentleman, a plastic surgeon by the name of Deepak Narayan, who has died now, but he was an amazing plastic surgeon. He was a very good friend of mine. He was a resident when I was a medical student, so we were really actually very, very close. There's a gentleman who fell into an industrial mixer and essentially it like mangled his arm from his fingertips to his shoulders. And so we did essentially every reconstructive procedure in the book. We did multiple free flaps where you're taking tissue from other parts of the body and reconstructing it using the blood supply, bringing in a microscope and reconnecting the nerves. We put fingers back on. We helped to fix the bones. We rebuilt part of the brachial plexus, the nerve supply for the arms. That operation took us 26 hours. And this is still, again, this is still a little bit of a legend. Yale, if you ever visit Yale, you can ask about this case. It's still kind of a very, very famous case. Within that 26-hour period, Dr. Narayan and myself took two 15-minute breaks each at different times. Um, and that was it for the entire case for 26 hours. And that means to eat, to pee, two 15-minute breaks. And I tell that story to talk about stamina and talk about what becoming a physician, at least in the old days, was about learning what your limits are, understanding what those limits were. And I remember at the end of that case, I was like, okay, I definitely feel that I am toast. I can barely think anymore. And I remember Deepak, Dr. Narayan said, okay, go round, because it was still the old days. He wasn't going to, let me go home and sleep. He's like, go round and then go home and sleep and then come back, and get back to work. And so I remember I was like, wow, I'm just like a man of iron. I'm just so tough. And like I did this, this case that I hadn't heard anybody else do, kind of put that much energy into successfully saving a guy's arm. Went home, came back like 8 hours later, and I learned that, or I guess it was about 12 hours later, I learned that Deepak had gone to clinic and then operated again that night on call. And it was just one of those moments where I was like, wow, you know, I felt like I'd really achieved the zenith of accomplishment, but there are people, especially in that kind of that older style of training, that had done so much more and were even stronger than, kind of what I thought was the limit. And so I think what's important about that story is work-life balance for kind of older, especially older surgeons. My patients don't want to hear work-life balance, right? The hospital administrators don't want to hear work-life balance. My staff don't want to hear work-life balance. They want to hear that I'm one of the best surgeons out there. They want to hear that I will be able to get their their family member or themselves, that patient, through surgery safely. They want to hear that that I won't make a mistake because I'm tired. And so I think work-life balance is challenging for surgery because there are moments where if you're tired, nobody cares. The lawyers don't care, the hospital administration doesn't care, the patients don't care. They just want the absolute best surgeon that they can find. And a lot of that means that sometimes work-life balance takes a second, and takes a back seat. Now, I think that's a very old type of perspective, and I think that nowadays things are better. And I think that you can carve out sections of your life that are just inviolate. You're like, look, for my kids, I need to have this period of time off. And I think that modern medicine is more accommodating to that. But just remember, that the lawyers don't care, the patients don't care. At some point, hospital administrators don't care. And while high school, medical school, college, those things are a little bit more protective of work-life balance, and it's certainly in the vernacular of discussion and kind of how we think about training nowadays. But at some point, it's still going to be you. So just a little bit of that. I'm just going to, again, I'm sorry if I'm getting too deeper off point. But question about plastic surgery. What made you choose plastic surgery? Plastic surgery is absolutely, in my opinion, the best specialty. And if you guys are thinking about medicine, I highly would suggest you don't even consider anything else. And I'm biased, obviously, but plastic surgery, we call it operation of the skin and its contents. Generally, plastic surgery involves some general surgery training as well as plastic surgery training. And we are really comfortable in almost any part of the body. The parts of the things, surgeries I wouldn't feel comfortable doing anymore, procedures operating on the liver, on solid organs like the liver. I've done kidney transplants before, but not for a very long time. And so spleens, livers, kidneys. But even when you think about bowel surgery, we are trained to rebuild esophaguses from bowel. We are trained to do microsurgery using parts of the bowel to rebuild things. We are trained to operate on every part of the body. When people say, well, what about the head? We're doing craniosynostosis operations in infants where we're taking the skull off and reshaping them. And so plastic surgery is incredible because there's an enormous amount of diversity to it. You can really um, build almost whatever type of practice you want. We operate on all ages. And plastic surgery also has an incredible flexibility in terms of compensation and reimbursement. And I think at for the people who are attending this webinar, you should not be embarrassed or ashamed to demand compensation for the sacrifices that you make to become a physician. And so plastic surgery is one of the few specialties that you're still really relatively flexible in finding ways to make the economics work, because while reconstructive and insurance-based fee for service medicine is contracting and becoming harder to navigate, fee for service cash pay aesthetic medicine is still reasonably solid, especially for a good plastic surgeon. And so you have that diversity of choice in terms of what directions. And so plastic surgery is highly competitive. It takes a long time to become a plastic surgeon, but I really feel like it gives you the most opportunity. I'm going to go again, just keep the questions coming. I'm sorry if I'm spending too long on them. Research opportunities. So this is a little bit of a challenge. So one of the things that's really changed in terms of getting into competitive medical schools, getting competitive residencies, it's really almost de facto or expected that you're all going to have uh, some sort of research background. And that's particularly challenging. And the reason why is because it's expected now. When I was a medical student, when I was a high school student, when I was an undergrad at Dartmouth, it was really, really, I mean, I had research, but it was probably less important than it is now. Now people are doing year-long research blocks, and those opportunities, because everybody is really expecting it, there's more competition to find those slots. And then if you look at the current, I'll call it administration, but the current, the governmental stance on the attacks on universities and threatening funding, at least for the next 2 or 3 years, those opportunities are going to become even more sparse for a couple reasons. Number one, universities are having to evaluate even the nature and the topic of their research. And so I'm not highly published. I have a lot of leadership roles. I do a lot of speaking, but some of my publications are around diversity. And it would be essentially impossible right now to get university funding or certainly federal funding to do a study on diversity. And when I say diversity, I'm talking about, let's look at the disparities in breast reconstruction rates for African American women versus non-African American women. It would be almost impossible to do research in that. And that's clearly something that continues to be a real issue in American healthcare. And so there's a limit for some research opportunities. But then because this funding's under threat, universities are striking travel. They're not hiring new research assistants. They're not expanding the faculty. And that means that dollars for additional research are going to be consolidated. It's going to make things a little bit harder. Now, the great thing is, again, I think that even if you're not potentially doing something that's university based, there are you can do kind of self-guided or self-directed research, especially with social media and those types of things. There are ways to kind of develop projects that explore things that you want, and then use that to get the attention maybe of research positions or universities. And also, the most important thing is, again, building networks. Part of the reason I like doing these speeches or these talks is because I want to be part of people's networks. And I really do try to be a resource. And I've worked, even in the last few months, I've worked with about 3 or 4 medical students and helped them to find some research opportunities. And so the easiest way to find me is on social media. I'm Surgeon in Black on Instagram. And if you see me there and you reach out to me, just make sure that you mention where I mentioned reaching out to me, because I get a lot of requests. And if I don't respond to you the first time, reach out again, because again, I get a lot of requests and it's hard for me to respond to everybody, sometimes in a timely fashion. The last piece of advice I'd say is, as you're looking for mentors, as you're building your network, make sure you're bringing value. And so if it's peer-to-peer research, make sure that you're also making your peers better, that you're supporting them in their journeys towards excellence and their journeys towards fulfilling their educational goals and dreams. If it's networking with someone like myself, what's less helpful is when a college student comes to me and says, I want to be a plastic surgeon. I want you to call some people, tell me, get me into some labs and set me up. Like, that's not helpful. And the reason why is because it puts all the onus on me. And it also kind of tells me that maybe you're not very serious about it. What's more helpful is someone who says, these are the 10 things I've done. Here are the universities that I've reached out to. Here are the specific people and departments that I've heard from, and they've said either yes or no, or they need more things. What's your advice? That's much more helpful, because sometimes I mean, I essentially know most people. So sometimes I can reach out to those people directly, but more often I can at least give a little bit of guidance. And so because you've done some of that work, you've taken some of the responsibility, it makes it easier for someone like myself to help you. So just think about that. All right, just going to the next thing here. How difficult was it to get into medical school and residency? Difficult, and it kind of remains difficult. So I told you a little about my college journey. The reason I told my parents I had to go to an Ivy League school is I knew I was a B student. I knew I was never going to be kind of a straight A student. And a B student then wasn't as bad as being a B student now, because I think things have gotten even more competitive. It's become a harder landscape to navigate, but it still wasn't great even back in the days. The one thing that I had is I had a very strong, again, I did very well on standardized tests. And I also had a very interesting story to tell about starting these companies and kind of doing this technology to kind of fund my way through my education. But part of the reason I told my parents I need to go to an Ivy League school is I recognized that I wasn't going to be an A student, and I needed the strength of that school name to help get me into the next level. And so when I applied to medical school out of Dartmouth, I applied to, I think, about 20 schools. I got into UMass. I got in relatively early. And so at that point, I took a sigh, I had a sigh of relief, because medical school is a little bit different than undergraduate, because once you're in medical school, you can really become whatever you want at any medical school in the United States. And so if you're in medical school, you are going to become a doctor like 96, 97%. Again, I think minority students sometimes have a little bit less of a success rate, and we can talk about some of that as well too. But there's a relatively solid chance that if you've done the work to get into a medical school, you're going to be fine. So I got into UMass and I kind of took a deep breath. I got waitlisted at Cornell. I got waitlisted at Yale, and I got waitlisted at a couple other schools. And I think I got in somewhere else. I'm sorry, I don't remember it, so I'm probably disrespecting that medical school. I'm sorry if someone looks it up and slams me online about it. But I got off Yale's waitlist relatively quickly, and that was kind of my dream, because it meant that my father also went to Yale, and that may have helped. I don't know how much of that legacy pulled. I don't think as much as people think it does, but I was able to get into Yale, and that was kind of a dream. But it was super, super hard, and it was super, super hard with really good test scores. And I think the challenge for you guys is it's even harder now. It really does seem like There's an incredible amount of pressure on people at a very, very young age when they really have fewer resources to manage it, when they really have less perspective on the world to be able to navigate the challenges. And, um, you know, I don't think I would have got into the schools now that I got into as when I was a kid. And so recognize that it's going to be a struggle, and the only thing you really have is resiliency and the ability to kind of try and try again. One of the things to think about for residency is for plastic surgeons. I know lots of plastic surgeons who actually didn't get into plastic surgery residencies and instead went through all of general surgery, which again, if you can be 7 or sometimes even 9 years because they force you to do research as part of that residency, and then did a plastic surgery fellowship, which was 2 or 3 years. And so they expanded their time of residency by years. And if you have student loans and things like that, by years. And if you're trying to start a family or settle down somewhere or figure out where you're going to live, all those decisions are delayed because wherever you're going to residency, you don't always choose it. I got into Yale for residency, but the match is completely random. And I would have gone anywhere. And I was very thankful to match. Um, and not everybody does. And so you have each of these escalating, more competitive, more challenging parts. But as you're going through them, it delays your life for the time that it takes you to complete those things. And so it's incredibly competitive. It's hard, but it's also largely impactful on your life. And so make sure it's something that you really want, and be prepared to have some resiliency around it, and be okay if it takes you years more than you want. And the reason that I think people are able to navigate it is because they don't really have any other choice. It's the only thing they want. It's the only thing that kind of that they're going to see as being a marker of success for that part of their life. So, all right, sorry, I'm going to go to the next question here. Love to talk about leadership. Yeah, okay. So, um, leadership's incredibly important right now, and I think especially amongst minority communities, it's particularly important. One of the things that has really changed, aside from again the current government position, um, the thing that probably had the most impact was the recent Supreme Court decision that changed the ruling on strict scrutiny regarding affirmative action. And it, that was probably challenging enough in terms of encouraging diversity and supporting minority students, but it also has a chilling effect on, I think, admissions and on even what students think about as they're considering medicine and as they're looking to really make these large life sacrifices as they're moving forward. And so it's increasingly important that we all act as leaders. And for the people on this call, it means turning around to high school students and mentoring them and showing them part of your journey and trying to open doors. For people like me who are in the middle or late parts of our careers, it means doing webinars like this or helping students. And that doesn't necessarily mean that, hey, if you know me, you're going to get in, you're great. But it means, at least me being able to provide some perspective and be supportive as there are fewer government programs, as universities sometimes hide in the shadows out of fear for supporting diversity and supporting underrepresented minorities. It means that each of us individually have to stand up and do our part. Now, the general premise for why some of these programs are being rolled back is that that was then, this is now. You shouldn't put the burden of correcting the wrongs of the past on the current generation because they had very little to do with those things. And there's probably some truth to that. The challenge is some of it has to be based on data. And when you look at, for example, African American men, essentially the enrollment in medical school, the percentage rate of enrollment in medical school is actually very similar to what it was in the 1970s. There hasn't really been a lot of progress. When you look at minorities actually completing the pathway to become physicians, that pathway is incredibly leaky. We lose people at a higher rate than any other organization or any other segment of population as defined by either economics or um, by demographics and ethnicity. And so when you see that, you know there's more work to be done. And I can't necessarily go to the Supreme Court and lobby them to change their decision, but I can individually use my voice and use my time to have meetings like this. And I've talked to crowds as big as, 1,000, 2,000 people about this topic. I've talked to crowds as small as 3 people. Every one of those conversations is equally important. And I want you to recognize yourselves as leaders now because you've already made progress. You've already started on the journey. You've already taken that first step. And if you've taken that first step, then you have an obligation to provide leadership in that space. And all those voices together are very, very powerful. And so that's kind of why I think leadership's important. And I speak a lot about leadership. So I hear surgeons have very rigorous residency hours. Yeah, and again, I'm an old man. You can see all the gray hair. Uh, in my opinion, this is like this. This is pretty easy nowadays. But that's probably not the right perspective. I do think that medical school students and residents have a much larger body of information to absorb. I think that things are more competitive, and so while I think that overall time is more protected now, um, the obligations are the obligations of learning are probably larger than when I was coming through my training because there's just more known. There's more medicine. There's more understanding of care pathways, disease pathways, and all of that is still a doctor's responsibility to absorb and learn. And so, it's easy for old guys like me or old people like me to say, "Oh, you guys have it so easy." But there are other things that are harder now than they were back then. I think the thing to think about in terms of the hours is residency and medical school to some extent too. It's a very, very special time. And what I mean by that is you're protected. It's this space where you can, for example, that 26-hour case where you learn your limits. I'm like, okay, after hour 24, 25, I'm pretty much done. I might not be making the best decisions, but you can find out about yourself and learn those things in a protected space. You have attendings, medicals, the medical school institution, these policies, these instructors are all around you to allow you to learn about yourselves. And so I think when you lean into work-life balance, or where you lean into, yep, 5 o'clock, that's my 80 hours, I'm done. Or, the medical school saying, well, you could go to this thing, but you don't have to. We don't want to put pressure on you. In some ways, you're cheating yourself a little bit. Now, I'm not saying that burnout isn't real. I'm not saying that people shouldn't be able to pursue meaningful relationships and things like that at any point in your life. I think that those days of kind of de-emphasizing the importance of those things are over, and it's probably good that they're over. But these are very special moments that you'll have that change who you are as a person, change who you are as a doctor. Kind of the crazy stuff happens at night, when you're a resident. And that's when you probably have more autonomy and have more access because, the attendings at home asleep. And so seeing those things, or even, I admitted this patient at 4 o'clock and I was with them at night, but then in the morning I could go home. You don't really get to see, well, what did they decide on rounds about? Did I make the right decision or what changes did they make? All those things are really, really important because when you're done, all those things are still your responsibility. And so I would say, as an old person trying to exist in modern education, work-life balance is important, but don't cheat yourselves in terms of taking advantage of that protected environment to really learn who you are as a physician, who you want to be as a physician, what it takes to provide excellent care to your patients. It's really, really important. And sometimes I think people focus a lot on the hours and the impact it has on their life. And especially as a surgeon, that's probably not completely correct or completely beneficial. And the second part of that question was gender affirming care. And so, gender affirming care, I think, has had a renaissance. I think it's definitely something that people talk about now. Again, in the current environment, there's a lot of pushback. I look at places like University of Miami. I have a very good friend of mine, Devinder Singh, who's the chief of plastic surgery there. He was my junior resident. they don't have a gender affirming care program. They can't even mention it. And so they actually have to send their patients to surrounding facilities. And that's probably a disservice. And I think at some point, when people have the ability to, so in gender affirming care in minors, I think is a very special, different subject because I think people have to have the ability to make conscientious decisions. I'm not always sure that minors are equipped, and there's a lot of confounding factors about minors making decisions about their healthcare. But in adults, I feel totally differently. Adults, it's about free will. It's about being able to control your body. And so, gender affirming care is one of those things that I think has it's had a renaissance, but there's a lot of active pushback right now. I think overall, it'll probably still be something that probably is a resource for patients. But right now, there's a little bit of pushback because things are challenging right now, and not every program is even allowing their surgeons to provide gender affirming care. So, next question. I'd love to dive into your experience fighting to be the best. What does it look like? Yeah, like I said, um, I think every person is a little bit different, and that's a very kind of blasé statement. But I think the most important thing is you have to find what that fire is for you. For me, it was probably, fighting against an internal inferiority complex that probably still drives me today. I just want to be the best. I want to have, everything at my disposal that, I want to do every hard thing there is to do. That doesn't necessarily have to be what drives you. You don't have to be kind of as crazy as I think that drives my wife and my family and everything else. It can just be simply this motivation to have to provide excellent care. So I know people who were inspired by a personal healthcare story that touched them or touched a family member, and that is incredibly powerful, and that's their driving force, and that can be just as effective. But I think the first step is finding what you really care about, because if you don't have that drive, what happens is you get that first 65% on a test where everyone else got, an A, and you're met with self-doubt, and you're met with sadness, and you're met with frustration, and that's going to beat you if you don't have something inside of you that's going to push you. This first time that you have a complication, right? I have a junior partner right now, and he had a patient that I thought he did a great job. This patient's like, this is a centimeter, like, this is supposed to be here, and it's here. Like literally, it was like, I think 8 millimeters. I measured it with him. Patient was really annoyed. He took it as a complication, which I thought was great that he really said, no, I want to provide this outrageous level of care. Um, and so I thought that was great. But he really took it hard because this patient that he worked so hard to provide this amazing aesthetic procedure for was unhappy. And what he went back to were the things that drive him, to say, you know what, I hear you. We're going to make it better. Here are the options. Instead of saying, oh my gosh, I did the best I thought I could do. I thought I nailed it. And this patient's miserable and super unhappy. If you don't have something on the inside that's going to drive you forward, at some point, those voices beat you. And so as you're kind of developing that, you get try to find what's going to drive you forward. And if you don't have it, you know, you have to have a strategy to what you're going to do when those bad things happen. I think there are ways to persevere without that internal drive, but they're harder. They're more challenging. So what are the cons of being a surgeon? Yeah, so being a surgeon is amazing, but it's really like the OR is my favorite place to be. I actually don't love the clinic. I like seeing kind of the results of my surgery, but new patients, it's nice meeting people and talking to people. My favorite place is to be in the operating room. And so the great things about surgery are it's completely in your hands. And again, we work with a team. I have an amazing team around me that really helps me to provide excellent care, but it's largely at your direction, and your planning, your insight, your technical expertise, and then your pre-op and post-operative course and what you're prescribing for those patients. That's incredibly important too. It's not just your time in the OR. And so I think that surgery is still one of the most um, it requires the highest level of excellence because there's not a lot of time to correct. if I prescribe a medication that for a patient who has hypertension, and I should have given them a slightly higher dose, come back in 2 or 3 weeks. Oh, your hypertension is still a little bit high. There's plenty of time to correct. If you do something wrong in the operating room, people can die. And so, and I'm not saying that people can't die with, internal medicine decisions or things like that, but there's every day there's that acuity, and um, you have to be able to thrive on it. And so that can be a con as well, that you're always under pressure, that it's always your fault if something's not perfect or if a patient gets hurt or is unhappy. You really have to be able to manage that pressure. And again, I've been, knock on wood, I've been incredibly lucky in life and in my practice. And I think part of it's hard work, part of it's my training. I've never had anybody die. I've never been sued. And those are actually relatively unusual things. And it's because I hold myself to a very high standard. I try to be very, very careful. And I don't even like saying that out loud, because it doesn't mean you don't have to be a bad surgeon to have those things happen to you. You can be an amazing surgeon. And people who train me, people who I think are some of the best surgeons in the world, they've had those things happen to them. But those things can happen, and that's really super scary as a surgeon. And when they happen, it's going to be largely something that maybe you could have prevented. Maybe it wasn't something that at that moment in time you could have done differently, but you're going to feel that weight on your shoulders. And I remember when I was a resident, when I was thinking about, I was heavily recruited by the general surgeons for trauma surgery. And I just remember having to go out and talk to family members of some 18-year-old who came in and was alive for, 30 seconds in the ER bay, but was, essentially going to die. And I remember talking to the family, and it was just incredibly painful. I really don't like patients dying. And I think that in some types of surgery, that's, you know, vascular surgery, cardiothoracic surgery, maybe neurosurgery, definitely trauma surgery. Those are things that are actually probably a more routine part of your practice, no matter how good a surgeon you are or how bad a surgeon you are. And for me, I didn't want anything like that. I'm like, well, plastic surgery, there's at least a lot less of that. And so you got to think about the emotional toll it's going to take on you in terms of what happens to your patients, sometimes in ways that are outside of your control. Surgery is still incredibly demanding in terms of how it impacts your family, how it impacts your friends and your lifestyle. And so think about that. Um, uh, Surgery is also relatively narrow. And one of the things I talk about are GLP-1s. And so everybody's probably on this call has probably heard about Ozempic or things like that. Um, Ozempic is going to change medicine because it actually it's one of those medications that actually is making a substantial impact on American health. Obesity is going to be much less of a problem going forward as these drugs become more prevalent, as they become better. And that means that there's going to be pressure on people to maybe not need as many doctors. And I think that highly specialized surgeons have fewer off routes. You're very, very specialized, which means that if the landscape of healthcare changes, it's harder for you to pivot. And so thing, those are some of the cons. But I think the things that are probably the most important to think about are that highly competitive, so tough to get into some of the specialties, and highly impactful on your life. In some ways, you're kind of a surgeon first and then everything else second, especially if it's 2 a.m. and your patients are calling you, or the ER is calling you. So just make sure that that's something that you're okay with. Thoughts on plastic surgery integrated residency programs as opposed to general surgery then fellowship? And so, great question. I generally think that the integrated pathways are more competitive because shorter period of time. You want to become a surgeon as fast as you can and still be trained well. And so that means that most people want those kind of more compressed pathways. I did a 3-and-3 program, so 3 years of general surgery, 3 years of plastic surgery. There are programs out there now that are 1 year of general surgery and plastic surgery. I generally think that I probably use less of the general surgery skills I learned in my everyday practice, but I do think that all those general surgery hours made me a better surgeon overall. Um, if I had the choice, coming out of medical school and I could go into whatever program I wanted, I would definitely do an integrated or combined program because, I wouldn't want the extra hours. So, um, my weekly work schedule. So again, I'm a little bit atypical, right? I'm an old man, again, gray hair. I'm in my 50s, and so I'm mid-life cycle. Like my practice, I probably have another, 10 years of productive surgery, and that's, probably middle to late practice. And I was president of the American Society of Plastic Surgeons, and it's relatively easy for us to recruit other great plastic surgeons. So I have a little bit more control over my lifestyle. I also have a spouse who works and who is very notable in her field and generates revenue as well too. And so um, because of that, I have some options. My weekly work schedule is largely based around what goals I have set for my company's development and less about what do I want to achieve financially. And again, huge blessing to be in that position. But generally, I generally work 5 days a week just because I'm obsessive. I'm usually in the office by 6 a.m. I usually leave by 6 or 7. There are nights when I try to pick up my kids because my wife's like, you haven't picked up the kids all week. It's your turn. Um, and so those days I'll leave a little bit earlier, 5 or 5:30. But I'm generally in the office about 12 hours a week. As early as 5 years ago, I would also be in the office on Saturdays. I've tried to eliminate that from my lifestyle. One of the luxuries I've taken is I don't take primary call anymore, although I did last week. I generally have my team take primary call. So first things that if my patient's saying, "Oh, can I take an extra pain medication or my drain's not working?" I don't want to get those calls at 2 a.m. anymore. And our team's pretty good at counseling our patients. So my practice as a whole doesn't get a lot of those calls, but it's just the one thing, the one luxury I'm taking. I don't, if something's wrong and they're on their way to the ER, oh my God, yes, call me, wake me up. We'll figure out what's going on. But I don't want to get called about a drain. So, other than that,
And
I try to be
can
pretty.
can you just tell them how many years of practice you were able to get to this? Because you can't do this as a
Yeah,
first
yeah.
year
So
resident.
yeah, thank you very much for correcting me. Yeah, so in residency, you should expect to be on call, every fourth night, things like that. In practice, when I first started, it was just me, and so I was on call all the time, and I did a fair amount of trauma coverage and reconstruction in my first few years, and so there were a fair amount of calls in the beginning. Um, and I've been in practice for almost 20 years now. And so in the beginning, the amount of support you're going to have to provide to your practice is going to be a lot higher than as you kind of get a little bit as you get a little bit more gray hair like I have. So how
And you also tell them like private practice, like you work for yourself, like
yeah.
you're the name is on the buck stops with you type of thing. So
Yeah, so super great point. Thank you very much and this is what I want. If I'm kind of wandering off or not answering the question well, just pull me back. And so, again, I'm a private practice plastic surgeon. The benefit of being at a university is you probably have a team of people that are sharing the call and sharing the work with you. The university is prescribing how your work hours are structured. And so you probably have probably a little bit more protection because there's probably going to be a little bit more advocacy for work-life balance, but it's going to be less under your control because the university is going to say, well, you have to take this much call on, the chairman of the department. He's on call too, but you just got there. And so you got to maybe take more of the ugly call than, the people who are more established. In private practice in the beginning, it's all you. It's always you because you can't. If a patient's calling, who else are they going to call? You can say go to the emergency department, but you still have to, interact with the emergency department. You have to meet the patient there and see what's going on. And in private practice plastic surgery, as as was mentioned, it is 100% your reputation. And if you're not there for your patients, if you're not interacting with your patients, patients aren't happy about it, and we'll let everyone know. And it probably wouldn't be a great way to try to build an aesthetic private practice.
and what you do is becoming more rare now that, you know, um
100%. It's a great point. This kind of concept, and we talked a little bit about the consolidation of healthcare in the beginning, but this kind of like, I'm just going to hang a shingle and open an office and like build something. That's incredible. That's more and more rare, even in plastic surgery. And the reason why is because people sometimes don't want to take the risk because there's risk. You're putting your money out there. You're putting you have to buy a building or you have to at least build out a practice. You have to advertise. People say, what's the hardest part of your day? The hardest part of my day actually isn't surgery. It's not medicine. The hardest part of my day is managing my team. And I don't mean that in a bad way. I have an amazing team, but I have about 25 employees, and someone's always upset about something, or someone needs to go on maternity leave, or someone called out sick. And I have great managers that help with that. But again, eventually the buck stops with me. And so the hardest part is managing the team, and thinking about that work-life balance for the team. And my work-life balance is secondary to my team's work-life balance. And so that's also a very important thing to think about as you're going through your education. I think it's easy to kind of and appropriate to think about work-life balance as you're going out, as you're kind of going through the system. But once you're done, especially if you're running your own practice, no one else cares about your work-life balance. They care about theirs first. And sometimes yours has to take a back seat to it. So there are very large differences between what lifestyle looks like between private practice and academic medicine. And even in private practice, especially outside of plastic surgery, fewer and fewer people are starting their own practices or acquiring small group practices. Those numbers are incredibly shrinking right now. So,
I mean, and you have the burden of 26 people's livelihood and,
yeah.
food in their stomach and
Yeah,
roof
you
over their
cannot
head. So,
bounce a paycheck. Nobody wants their paycheck to bounce. Their
yeah,
paycheck
and so
is
like you have that huge,
there.
so that big responsibility of managing, managing, but also like, like I ran a business and I could tell you like it wasn't something like the palpitations that I had was making sure like all my employees would get their checks at the end of the month because they
Yep.
have families and other things. And so it's not also like, you would have to like see them every day. You'd be like, oh, or if you do bad one year and you're not giving out, bonuses and the other stuff. So it has a huge impact on you. And like I think like that that old I don't know. To me, it's just I find it very rare the old setting of having like a solo practice and managing people. I think it's becoming less and less, but it's still out there. And I think the beauty of medicine is you could practice however you want. Whatever you want to do, like you have that autonomy to do it. Where if you were a PA or other things, you couldn't do it, but you have but it's also like with great what is it with great power
Comes great
becomes
responsibility.
yeah.
That's right.
So I
To
think like
those,
that.
yeah, to those that's given much, much is expected. I tell my kids that all the time.
Yeah.
But I think that you're exactly right, and so, as everyone's thinking about what their career looks like, it is important to recognize that insurance reimbursement is incredibly complicated to navigate, and that's on purpose. The insurance companies want to keep their money. And so if you're opening up a small practice that maybe is all reconstructive plastic surgery or some other specialty that relies on billing, like non-aesthetic dermatology or internal medicine, or pediatrics. Those things are really hard to do right now because you really need a team. You need like 4 or 5 people that just handle billing. And so it's really hard to think about, well, I just came out of residency. I have all the student debt. And now it's not just about my salary. Now I have to hire at least 2 or 3 more people. One of them, their sole job is to get me paid, and I've got to
Hmm.
make sure I understand how that works. It's intimidating. So I completely understand that. Again, the nice thing about plastic surgery is you can just say, well, I'm just going to do cash pay, and I'm largely going to do aesthetic surgery. And in some ways, I think that's great for plastic surgeons. In some ways, it's really bad for American healthcare because it means there are fewer people doing breast reconstructions, or fewer people doing cancer reconstructions or trauma reconstructions. Universities are kind of overwhelmed because someone like myself, I love doing reconstructive surgery. I love microsurgery. I love breast reconstructive surgery, but I can't pay my team trying to be that type of surgeon, even as established as I am, even with my ability to negotiate with the insurers, saying, "Don't you know who I am?" It only goes so far, and I couldn't build what I have relying on insurance. And so, as you're thinking about your pathway and saying I'm going to go through this pathway, that probably means if you want to do things that are going to be reimbursed by insurance, you almost have to now be with a large healthcare provider like a Kaiser or a Sutter, or you almost have to be with a university system or a large medical healthcare system. It's almost
And,
impossible to
and
do
the good thing, if you're a pre-med student, you don't have to think about this for a long
at
time.
all. at
But
all.
somebody asked a good question. What if you want to be part of a group or work for a Kaiser,
Yeah.
or can you do that as a plastic surgeon? And that's
Yeah, and
yes.
so when I first came out of residency, I actually worked for Kaiser for 2 years, and I started a section of microsurgery for them, and then I started a section of plastic surgery for them in Central Valley. And so you definitely can. Kaiser hires plastic surgeons. The largely what Kaiser plastic surgeons do are breast reconstruction, paniculectomies, and breast reductions. They do a little bit of skin cancer reconstruction. They don't do
Can you tell me what pennilectomy is? Because I don't
Oh
think
yeah, I'm
most
sorry.
people would
So
know.
massive weight loss.
Yeah.
For people who lose a lot of weight loss, they have a lot of skin. That skin can get irritated, have wounds. It's There are issues with hygiene, there are issues with mobility, and so as plastic surgeons, you can remove that skin. It's typically covered by insurance, and so you can definitely be a plastic surgeon and work for large healthcare groups because there are parts of healthcare that are mandated to be covered that fall within that plastic surgery realm.
Yeah, and I think somebody asked about like what's like, and plastic surgery is just a lot more than just aesthetic. There is
Yeah.
burn and there is like
Hand
so
surgery. There are plastic surgeons who all they do is
micro,
hand
yeah.
surgery. Yep.
Yeah. Yeah, one of my really good friends, he's a pediatric hand surgeon in the Central Valley, and that's all he does. And I even made a joke about him. I was like, "Can you make me look pretty?" And he's like, "Well, that's not the kind of surgery that I've done in a while, but
Yeah, as a plastic surgeon, when you take your boards, you are required to know hand surgery. So you can't say, "Well, I am a plastic surgeon, but I really just want to do boobs and tummies." Like, no, like show us you know how to, deal with an arthritic hand. Show us you know how to do a replant. Show us you know how to manage a tendon laceration. All those things are very core to plastic surgery. And if you don't know how to do it, you will not become board certified. You probably won't complete your residency. So. A couple other questions here. How can students start prepping early if they're passionate about surgery and healthcare innovation? Oh, that's a great question. I do think that technology has become so accessible that there really are some great ways that people can be very impactful in terms of healthcare innovation. When you look at AI, when you look at social media, in terms of its outreach and power to spread messages, there's so much work you could do there. In some ways, when I talk to my friends who were very very successful in business, and I'm one of the poorest out of my friends, in terms of I know some billionaires, and they're like, well, why didn't you just stick with your technology company that you founded, because you could have been like us. And what I tell them is, technology is probably very very powerful in terms of if you're starting your own company, if you have your own idea, the ramp up is probably more powerful than anything you could do in medicine, in terms of wealth accumulation, I guess, which is not the only metric in life. I will definitely say that, but it's not as assured. And so that's what I tell people. I'm like, look, I had a tech company and I successfully exited and sold it for some money, and that money helped to fund my practice starting. But if you're going to become a doctor, it's unlikely you're going to be poor living out on the streets, right? No matter what healthcare pivots to, it's such a long road, and it's so competitive that no matter what field of medicine you go into, you're probably going to be fine. And so
so you were never homeless. You're able to have a house and
I mean,
a
there were
car.
times in medical school where and in residency where things were tight. When I was dating my wife, she would come over, and I was a resident when we were dating.
So
Um,
she didn't marry you for your money.
no, she calls me her project because she would come over to my apartment and the power would be off because I didn't pay the bills. And I didn't really care because I wasn't home at all anyway. I was in the hospital most of the time, but she would just be embarrassed for me. She'd be like, "How can you not at least manage your finances?" And I'm like, "You don't understand. I'm tired."
Hey, whatever worked for you, right? You're able
Yeah.
to get marry you. No, but I think I think for us that live in the Bay Area is the idea of money and income is so skewed that
Yeah.
the rest of the
100%.
world is not like. I mean, if you compare yourself as a surgeon to the tech billionaires, yeah, you're underpaid, but at the end of the day, like we all don't fly, need to fly. We don't need to have private jets and
So yeah,
mansions. I mean, at some point, like
I speak to the corrosive power of social media all the time. Social media is incredibly powerful in terms of building communities, in terms of spreading messages, in terms of finding information. But it generally isn't reality. And I'm sure everyone on this call has heard or thought about that. The things that you see that are promoted are people's perfect lives and generally aren't even real. And I have doctors come to me all the time because I have this technology background, and I'm still very involved in technology initiatives at ASPS, and we have a venture fund where we're vetting companies to give them startup access to capital and partners. And so that's also a very big part of my life right now because of my background. But I have doctors who come to me all the time and say, I've got this great idea and I'm going to be the next Mark Zuckerberg. And I laugh at them. And they're like, well, what? I'm just as smart as they are. I'm like, you're definitely as smart as they are, but you're not going to be able to do it. And they say, why? And I say, well, as a physician, are you going to mortgage your house, sell everything you own, live on someone's couch, and just put it all out there? And they said, well, no, because I'm making, $500,000 a year, and I don't want to give that up. I said, that's why you won't make it. There are a million good ideas. If you guys want a good idea, I'll give you guys a good idea right now. And if you guys want to run with it, this is a fantastic idea. This is at least a $500 million idea. Um, Using AI, map your facial motor functions to track disease processes like Bell's palsy or Botox. And so a patient can take a picture of their face, they can do an expression, they can see, oh, my 11s are back, and the app will say, oh, time for you to go to Botox. The plastic surgeons will buy it because it feeds patients into their practice. Patients love AI and is tracking their overall motor function, and it's applicable to aesthetic medicine. And $1 million idea easily. Why do I'm not asking you guys to sign NDAs. Again, in California, that's very popular. I'm not asking you guys to sign NDAs. And if you want to take that idea and make something out of it, congratulations, that's great. I was happy that I could be part of your success. The reality is that it takes so much more than a good idea. There are so many good ideas. I hear good ideas all the time. The problem is it takes that resiliency we were talking about before. It takes this amazing amount of dedication, and it takes some timing, and it takes a little bit of luck. The market space has to be right. You have to be surrounded by the right people. There's a million different things that have to come together to make it work. And the reason I tell doctors in their 40s that they're delusional is because you're not going to be resilient enough. You're not going to sacrifice everything. The reason that Mark Zuckerberg, made it work was because he had nothing else to lose. Now he dropped out of Harvard, so you could say, well, that was a big risk. But if it all falls apart, who cares? I was 21 or I was 19. I can just start again. I didn't have a lot to lose. Once you're in your 40s and you have a family and you have a house, you're not going to put all that at risk. That's the first thing. And the second thing is these are incredibly, incredibly rare success stories that are all on the tips of our tongue because they're kind of forced down our throat. The reality is 99% of those ideas fail. It just happened to be that those are super, super in your face. And if you could,
The outliers.
yeah, they're complete outliers. And there's a book called The Black Swan. There's a book called Outliers. Those are actually really, really great books to read in terms of kind of understanding perspective and bias. And I think that would be really, really
But
helpful.
also, I think taking into account, Mark Zuckerberg's dad is a physician and his mom
Mhm.
was a lawyer, so he could drop out of Harvard. Or
Right.
Jeff Bezos, his dad gave him at that time in '70s $250,000, which is considered like $7 million today. So I mean, like those are great things that we could all aspire to, but you have to look at the underlying. But I think it's at some point like
Yeah, and,
some of
and
it has
the
to do with luck and some of it has to do with,
Yeah, and the other thing I'll say is, there is this skewed perspective on what wealth really looks like and what wealth really is. And you mentioned before that I was underpaid compared to, I am not underpaid. I am paid very, very well. And I don't want to speak about specific numbers, but a busy private practice plastic surgeon at my age, you should be generating more than $1 million a year. And so, it's hard to say that someone, in my perspective, should be generating at least that and then call it underpaid. Am I a billionaire? No, but that's the whole dystopian, warped perspective thing we're going through right now, right? It's there's this expectation of what wealth is supposed to look like and what it's supposed to have, and it's not really reality, actually. And I think that I'll give you some financial advice for the people on the call. I think the most important thing is start saving early. Don't go into tons of unmanageable debt. And some deferred gratification is incredibly powerful, because the real thing that makes people wealthy is actually saving early. That's the thing that gives, or rich parents, as you mentioned before. Rich parents help
Yeah,
too.
yeah. I'm looking for that to, if you,
Yeah,
if
me
you if you
too.
find that.
I'll take it being adopted in a heartbeat.
No, but I think, yeah, and I think, like, I think the what I meant, like, being paid, like, I think you're underpaid compared to a CEO of Google or whatever,
Yeah,
but
maybe.
compared to the average American, yes, you are, you know, you are living comfortably. But I think, like, what I always tell people is that there's this skewed idea of, like, I was talking to someone the other day, and I was like, yeah, the average physician starting out in the U.S. makes $250,000 a year. I'm like, well, that's not a lot of money. And I'm like, what do you mean?
It's a
That's
lot
like,
of money.
that's a lot of money. Like, like, to somebody who hasn't made that kind of money, like, make that first before you sit down and tell
Yeah.
me that that's not, like, that's
Now, the one asterisk, the one caveat I'll put to it is it is a lot of money, but sometimes it's not a lot of money when you think about what it took to get there and how much
right.
debt. And so if you're making 250 a year, but you have $1 million of debt or 1.5 million of debt, and that's carrying a 10% interest rate that you've been building up for the last decade because you've been in school, I don't know that, it's okay. You'll pay it off eventually, but that's not great. And the other thing, and this is probably the worst thing about becoming a doctor, especially a surgeon, is you're giving away your 20s. I mean, you're really sacrificing that time. And so you have to have earnings compensate you at some point, because you've given away a decade of your life. And again, I think it's 100% okay for physicians to demand compensation for those types of sacrifices. So,
But I also think, like, you have to look at it from a perspective, and I tell people all the time on this calls, like, when they come, if you want to go start a business, you got to take out some kind of loan, and, whatever it is. And as a physician, you're going to have to take out some sort of loan to get that. But you make $250,000 starting out versus, most people now go buy a house for $600,000-700,000 in California, and you make $100,000. Like, that's, but your income as a physician grows every year, where other
hopefully,
positions is like 3%, growth, even if you get that. Like, I work as, I work in, we get like 2%, and we're like, yes, but, you know, physicians have a growth, and all these other things. And so I think it's just an investment. Like, your
it's an investment.
student loans is an investment. It actually has a lower interest rate than if you take a business loan, but that's a whole different
Most of the
subject. Yeah.
time. Most of the
Yes.
So a couple other questions, just because I know we're going to wrap up soon.
Yeah.
But best way to reach out to plastic surgeons or find plastic surgeons for mentoring is also a question about MS1s. I think the main thing, and I kind of referenced this a little bit before, is try to build a network. Schools or universities, even community colleges, usually have some affiliation, or some local university that they have some connection to. Those are generally great places to start. Um, it's hard for people like myself to answer every question or to kind of be the perfect mentor for everyone. And so I do what I can, clearly. Again, Saturday morning we're here, but try locally first. I think that makes a lot of sense. And you're probably going to get better advice, because the people around you in those communities are more, they have more input and more insight into that particular university or program, or at least that area's recruitment protocols. And but you can reach out to me. I'm happy to try to help. I just can't guarantee. I get like 10 to 15 requests like a week for mentorship, and so I try to do what I can for everyone, but it's a lot. Last couple questions. What characteristic made me stand out? That's a good question. I think some of the things I did early on, I think having a technology company that I exited from um, provided some value to the American Society of Plastic Surgeons, because I had some insight and expertise that maybe the typical physician didn't have. I think that there are multiple pathways to success. I know people who have found leadership positions because of advocacy work, or because of work in building effective education for medical students, college students, residents. Uh, I tend to be more of a populist type of leader, meaning that I care about interacting with people and elevating individuals in terms of platforming them and giving them an opportunity to achieve those things. That's kind of what I was kind of known for in my presidency. But, the great thing about leaders is they come from every different background, every different stripe, and you just have to kind of find what speaks to you. What does breaking barriers look like in the current era? I mean, I think the most important thing is, at least in the short term, there's going to be definitely pushback on diversity. DEI is a bad word right now. And, I think the nice thing is, I don't think it's going to be sustainable because there's just too many brown people now. Compared to maybe in the 1940s, this would have been really powerful, or maybe even the 1970s. But I'm hoping that generally um, this pressure that people shouldn't have equal voices, that people shouldn't have equal opportunity. I'm not a quotas person, but I am a person that believes that there are inherent structural things in place that disadvantage women, that disadvantage underrepresented minorities, that disadvantage people of particular religious backgrounds, or have particular sexual identities. And I think that because those things are in place, there has to be some sort of pushback against that. I think that the easiest place to see where voices can be effective is in that fight right now, because that's kind of very much a hotbed, and there's a lot of active pushback from things that we thought we had made permanent progress on that we clearly haven't. So, clinical experience for medical school applicants: don't care, don't care, don't care. And I know it sounds really flippant. I think it's good that you're in healthcare situations, evaluating, working with patients. When I have medical students come to me and say, "I'm really good at sewing or suturing," it's like, what? Like, number one, no, you're not. And the reason I say that isn't to be egotistical. I tell people, so when I have PAs, residents, or other surgeons come to me and we're doing cases together, I tell them I learn something about suturing every day. Like, I try to make my suturing better every day. I don't think I'm the most amazing suturer in the world. So there's zero chance that you could be as a medical student. It's just not possible.
Can
Um,
I just add this is that as a pre-med student, you should not have suture kits. Well, I mean, if that's something that's going to motivate you, do it, but or don't go to a conference and you have like deans of admission and all these different people and you go to a suturing clinic. Like,
yeah.
don't do that. That's you and what Dr. Williams said is that you have plenty of time to practice that in medical school and residency. So like,
So
and it's
yeah.
it's a pretty easy thing to do.
Well, I don't
I
know if
mean,
it's
the easy thing to learn by
yeah,
doing, but I'm
yeah,
just saying, like, it's an easy thing to like get the concept of it, and
yeah.
then you just practice, practice,
And it takes a
practice.
lifetime to
Yeah.
perfect it. One of the stories I like telling stories. I like kind of interacting with people by telling stories. One of the stories that I really remember is at Yale, they let the residents interview the residents who were incoming. And there are people like, you're like, oh, I could totally see working with this person. That would be awesome. Or you could be like, oh my gosh, definitely not. Oh my God, I hope they don't match here. But one of the things for people that we would like, they would be like, no, I want to be a plastic surgeon because I'm really artistic. We're like, oh my God, don't say that. Like, look, piece of advice, don't say that you're artistic and that's what's going to make you a good plastic surgeon, because it's not what makes you a good plastic surgeon. What makes you a good plastic surgeon is being a good doctor. And that means that you're never tired of trying to help patients. You're never tired of trying to learn. You're never tired of being there when you're needed, that you're incredibly responsible, that you're incredibly intellectually curious. Those are the things that make good doctors, not that, oh, I'm good at drawing, or I'm good at sculpting. I can carve an ear out of a piece of wood. That's what makes me a good plastic surgeon. It's just nonsense. And in some ways, as you guys are progressing and thinking about your journey from high school to college, from college to medical school, or from college to a different college, or from medical school to residency, that's the thing to think about, is like, what makes these leaders successful? Like, am I an artist? I mean, like, yeah, I do a lot of photography. I appreciate aesthetics. But like, am I an incredible artist? No. And would that be the first thing that I would tell my patients? And like, you can see sometimes online, like, doctors like, well, plastic surgeons like, you should come to my practice because I'm an artist. It's BS. And they may be saying it just because it's in the popular vernacular, but doesn't make you a good doctor. It's probably the least important thing. So, so just you have to find those qualities that are transformational as you're going between those levels. And the way to identify those is find leaders that you think are doing a really good job. And they can even be people who you find online or on YouTube. There's all sorts of inspirational stories or people who are trying to help and give their perspectives. And so kind of find those qualities that made those people, that open doorways for those people. And so things to think about as a medical student, again, intellectual curiosity, say, look, I was curious about this one thing in medicine. And so I did this research and I tried to come up with research ideas. And, you know, like that is a lot more valuable than like, oh, I could suture. It's like, I don't care. Like, I care about what kind of doctor you're going to be. You can teach like, a monkey to sew. It's hard to teach them to be intellectually curious about human beings in healthcare.
One of our attendees just said that last night.
Yeah. I mean, it's not rocket science, but it's harder to teach someone to be responsible to show up at 2 a.m. when they're really, really tired and a patient needs you. That's hard to teach. That needs to be a little bit inherent. So, okay, last question I'm going to answer. So, surgeon I admire, and again, I'll tell a story to kind of close this out. I appreciate everybody's patience. There's a guy by the name of John Persing who just stepped down as chair of plastic surgery at Yale, and he's the one that opened doors for me. And he was again world famous plastic surgeon, um, but he didn't have to let me into the program. And he let me into the program when other plastic surgeons at Yale, fortunately not university guys, but some community guys said, we don't need niggers in this program. Literally said that, when my application came across their desk. And so, he is always someone who I think advocates for excellence, but also kind of thought about opening doors for people who may not have had those opportunities. Now, if he hadn't let me in, I would have gotten in somewhere eventually because that's just who I am. I'm just not going to like accept no. But it may have been another 10 years. And so I really I admire him not because he let me in, but because of his perspective on education and on his perspective on the importance of leadership. He was the same person who said, you need to get involved in our national society, American Society of Plastic Surgeons. You need to have your voice there. You need to understand what they're doing because it helps patients, it helps the specialty, it helps other doctors. And he's part of the reason why I became president. And in my presidential year, we get to kind of nominate and honor people and they give them this big award and things like that. And so he was one of the people that I put on stage because he was a great plastic surgeon. Yes, he did amazing patient care. Yes, he has an unbelievable resume in terms of publications and intellectual works. But the thing that was most impactful is he taught me how to be a leader. He taught me the power of opening doors and taking a little bit of yourself and giving it to others. And so that's what I would really recommend you guys look for in your mentors, but also the thing that you find within yourself so you can mentor other people. So
We all stand on shoulders of giants.
100%.
Well, it's 11:30, and if we keep you any longer, then we're gonna have to, you know, start start having to do favors. So,
Yeah, I'll make you guys see my patients. I'll make you do rounds with me.
yes. Well, thank you again for making yourself available. Also, I think your staff have been wonderful in coordinating your talk, and so
I have a great team.
definitely thank them. And thank you again for making yourself available. Thank you for joining.
Of course, good luck to
And
everyone. And if there's something specific I can do to help out, reach out to me. The easiest way is probably online. But I wish you all the best of luck, and I think you're all going to be incredible. So
thank you, sir.
thank you. Have a good day, guys.
Thanks.